Hi, this is Scott Miller. Welcome to my Top Performance blog. Today I have the pleasure of speaking with Dr. F, who is a physician in my home state and who has been really deep in dealing with the consequences of the COVID-19 crisis. Welcome, Dr. F.
Hello, everyone. I'm glad to be there.
And I'm really grateful that you would speak to me about this because there is so much news and it's really hard for people to get a handle on exactly what's going on, what the risks are, etc. And of course, I thought of you because you're a person who deals not only in this specific instance with COVID-19, but with death and dying on a daily basis.
That's correct, yes.
And so would you just give the listeners an idea about your experience thus far in Chicago with the outbreak? What are you noticing? What's happening? What are you seeing?
It is much more severe than we anticipated in the beginning. It does cause widespread shortage of everything. And it does cause significant mortality, way above what we usually experience. It gives us really a pause to think, are we doing the right thing in general? Are we prepared? We're obviously not. So it drains all our resources.
So even though you're dealing with death and dying on a daily basis, this is extraordinary.
It is absolutely extraordinary in terms of the number of patients and in terms of the feeling of what to do. We don't have a clear directives.
And with that, Dr. F, has it made it more difficult for you, both personally and professionally, to address the deaths that are happening?
Well, it is certainly difficult, but like every physician in this situation, we develop certain mechanisms how to protect ourselves. Yes.
And how would you describe those mechanisms? Because, as you say, this is extraordinary, but death and dying is a regular part of your work as a physician and the type of care that you do. What kind of mechanisms are those?
Well, the main mechanism, I would say, is trying to depersonalize the whole thing. So the patients, the specific of this epidemic is that you do not have a daily contact with every patient for a prolonged period of time. You actually try to limit your contact with the patient because your risk of infections is increasing as long as you spend with the patient, regardless of protective measures, which we're of course using. So the patients are much more confined in their rooms and not visible to us, which makes it psychologically easier to deal with that. Sometimes I noticed that even the nurses who work with me, who actually spend a lot of time with the patient, they seem to be forgetting the sex of the patient. They seem to refer to the patient as a certain number, which is not something typically happens, but that's certainly a mechanism to distance yourself from this subject.
And are there people who do sort of get beyond your distancing measures, so to speak, your psychologically distancing measures?
Yes.
That
what we often have are the primary care doctors. Not many of them like to come to the ICU, unfortunately, but some of them do, and I always highly regard these people, and I don't necessarily want them to go into patients' rooms, but they serve as a reminder that these people have a personality, soul, family, and so on and so on.
And do you suppose that if the patients knew that their physicians were distancing, that would harm them in some way?
Well, emotions are always dangerous because we sometimes make wrong decisions on the basis of emotions. We should have emotions, I think, in general, because otherwise this work cannot be sustained over a longer period of time. But the patients luckily also don't realize that because they're deeply sedated.
So what keeps you at it, Dr. F? What, besides it being your job, what keeps you going in there, facing this, being a person with emotions that knows that at some level they have to distance themselves? What keeps you going back day after day?
You basically realize that this is your moment in life, sometimes something which doesn't happen very often. This is the moment where you can prove yourself in some way, not necessarily to achieve positive results, but to be in the middle of that. Also, in my experience, when I talk to my other colleagues, other physicians who stay at home, not because they're afraid, but because they really have nothing to do there, they feel much worse than me in many times. So I'm actually, in a way, I'm not fortunate, but there's a definitely positive side on being there and not being at home in front of the New York Times or other media bombarding you with numbers of patients who died.
Yeah.
Because as we know, the news is always bad news. So I rather don't look at my media apps and see how many patients died yesterday in Illinois, but do what I can do.
Yeah. And in terms of expectations that patients have about living when they have, because I also know that your experience leads you to working with many people who are in fact terminal, that the chances of them getting out of the experience alive are very slim. How do you help those people develop expectations or realistic expectations?
Well, we have unrealistic expectations all the time. Basically, this is something. How I deal with that, I try to limit my conversations, if it happens, to a very simple one. I typically never bring in my conversations possibilities. I avoid if, buts, maybe, possibly, why don't we? I basically say 1 + 1 = 2. Mm-hmm. And if the person asks me again the question, but if that, I'll answer 1 + 1 = 2. It has to be very simple, straightforward conversation without repetition and without possible options. If I feel that there's no options, obviously.
And is there something that you feel like we should do as potential patients when it comes to facing these kinds of life decisions? How we prepare, how we prepare to interact with medical staff like yourself?
Well, I mean, the main problem is that the public is under impression that modern medicine has limitless possibilities, and if the patient comes to the hospital, that he is safe, that the hospital is not a place where we die. In reality, it's quite opposite. The hospital is the place where most of us die, and not at home.
Yeah.
So to have some more realistic expectations about our abilities to sustain life is important. Number one. Number two, it is important to understand that not every one of us should die in a hospital. This is not a good place to die in general. It is better to do that at home, surrounded by the family. So then we would not have so many terminally ill patients who are basically left for us to take care of them, although our interventions are very limited.
And is this something that the patients come in, or do you feel as though as well that modern medicine fosters that belief, or is that the media's sort of fault?
It's a combination of media and probably media in general, because we see billboards where it's written hospital so and so on at the forefront of medicine, where miracles happen, something like this. Yes. We all like to believe in medicine making miracles, specifically critical care. we see action movies where a single elite soldier can defeat an army of enemies.
Yeah.
So critical care is perceived as something like that you are elite unit, which is defeating the overwhelming enemy. In reality, we all know that the victory is not achieved by elite soldiers. The victory is achieved by regular soldiers in trenches. So elite soldiers can only accomplish very limited and small tasks, which are overall unimportant.
Right.
The same happens with me and other my colleagues, critical care physicians. We can accomplish only limited goals.
And so if patients, if the public had similar ideas and approaches, perhaps that would be an advantage. More people would in fact be comfortable staying at home during those final days, whether it's this or due to another terminal illness.
Well, the other, of course, major factor is a feeling of guilt, because often the family member who was indeed neglected during his lifetime or perceived to be neglected is dying, and his family members are trying to do everything for him. Just like our society is prepared to spend hundreds of thousands of dollars in the last final days of life of a certain person, but is not prepared to give the same person even a fraction of the same money during his lifetime.
Right.
So that should be addressed, of course, too.
I want to thank you so much for taking the time out today to speak with me. And I'll just tell the people who are listening that Dr. F and I had actually been planning to meet earlier, but he was called away on an urgent medical matter. So I'm grateful that you would provide this glimpse into your world and give us the pearls of wisdom you've given us today. Thanks very much.
My pleasure. Bye-bye.